Hello and welcome. My name is Julia Chen. I'm the Activities Director at the Yale Club, and I'm very excited to welcome you all to our virtual lecture series, where we bring in a live speaker to do a talk and a Q&A that you can participate in from the comfort of your homes. Today, we are excited to welcome Dr. Emma Lowe. Dr. Lowe is an assistant professor of psychiatry at the Yale University School of Medicine and a psychiatrist at the Connecticut Mental Health Center in New Haven. She is the founder and attending psychiatrist of the Street Psychiatry Program, which does mental health outreach to unsheltered homeless people living outside, using an approach of relationship building and engagement in order to promote healthcare equality and increase access to mental health treatment. Originally from Connecticut, she left to attend Haverford College, where she studied the fine arts and first volunteered doing homeless outreach. She later combined those interests by painting portraits of homeless people living in Philadelphia for her senior thesis, in an effort to humanize this misunderstood population. She then worked in Pittsburgh at a street medicine organization, where she learned from Dr. Jim Withers, one of the fathers of street medicine. She studied street medicine abroad in Kolkata, India, and did rural village health worker training and health infrastructure work in Kisara, Uganda. While attending medical school at the University of Rochester, she developed a student-run street medicine program, UR Street Outreach, and nurtured an interest in psychiatry. She returned to New Haven for training in psychiatry at Yale, where the mental health disparities and gaps in our current system propelled her to design and implement the street psychiatry program. Her research interests lie in the areas of understanding the unique needs of mental health care delivery, of unsheltered homeless populations, creating meaning in street medicine experiences for medical trainees, and innovation in mental health care delivery. She is an active member of the Street Medicine Institute and faculty advisor on the Learning and Education Advisory Panel for the Street Medicine Institute Student Coalition. Today, Dr. Lowe joins us to speak about the philosophy and practice of street psychiatry, discuss the mental health needs of homeless populations, the barriers to healthcare faced by people on the streets, and how street psychiatry serves as a non-judgmental, patient-centered approach to fill gaps in a broken system. And with that, I'll turn it over to you, Dr. Lowe.
Thank you so much for the kind introduction, and it's an honor to be here. So I'll get started by sharing my screen with you guys. So I'll just say that the art in this presentation is my own art. As you heard, that I studied fine arts. So hope you enjoy. I wanted to start off by talking a little bit about what street psychiatry is, since many of you might not have heard of it. It comes out of the practice of street medicine, which means providing primary care to people who are living on the streets through this kind of street-based outreach. You can see this is actually one of my mentors, Dr. Withers, who was mentioned, doing street medicine in Pittsburgh. In the same way, street psychiatry means practicing mental health care and offering substance use disorder treatment to people who are living on the streets, who might be in parks, under bridges, or other community-based places. And generally, these are people who are homeless or houseless. So the philosophy of street psychiatry, as you can see, is all about going to the people and literally and figuratively meeting them where they're at on the streets. And you might have heard of other similar approaches, such as ACT, which stands for Assertive Community Treatment. And it's one kind of model in psychiatry that involves usually home visits to people who are experiencing a very severe form of mental illness. These people may or may not be homeless, and usually the ACT team is kind of fixed as a certain caseload number, and they don't always take that many new patients. Meanwhile, street psychiatry is similar in that it's all about engagement in the community, but we are looking for new clients in the community that have not yet encountered mental health or have lost touch with their mental health treaters. And maybe in the future they would be eligible for an ACT team, but we're kind of the precursor to a formalized treatment program like ACT. And similarly, outreach and engagement, or street outreach, is another practice that is usually done to engage homeless people on the streets, usually in order to connect them with services such as housing. And these people that they're targeting are not necessarily mentally ill, but they may be. And these kinds of teams generally don't have a clinical component, meaning they don't have a psychiatrist or a doctor necessarily embedded in them. And street psychiatry, on the other hand, does have a specifically clinical component, which is what makes it unique. And all of these have in common in that we're going to people, not judging them, engaging them right in the community wherever they are. And this isn't a brand new idea. There's actually people doing street medicine and street psychiatry all over the country and all over the world. And the Street Medicine Institute is one of the places that was founded in the, about 20 years ago, that has brought all of these programs together once a year in an annual symposium. And so I've gotten to learn about a lot of different programs through this network that was started by Jim Withers. And some of the key programs that I want to highlight are the Operation Safety Net in Pittsburgh, Boston Healthcare for the Homeless in Boston, and Janian Healthcare, or Project for Psychiatric Outreach to the Homeless in New York City. Those are some of the biggest programs that offer street medicine and street psychiatry. And some of the other programs that I've had the luck to visit, or at least meet the people in charge of these programs, are at Vanderbilt, in Atlanta, in Jacksonville, Florida, and in Providence, Rhode Island. So why is street psychiatry so important? I think that what we've noticed in the mental health care field is that there's a number of patients that fall into this category of more chronic and severe mental illness. And these tend to be people who are less likely to receive care and are harder to engage. And often these people happen to also be homeless, and would otherwise fall through the cracks and maybe not seek care in traditional ways for a number of barriers. Some of the barriers that people face when accessing care can include things like feeling alienated and stigmatized from the system, which can be something that we as healthcare providers created and continue to perpetuate by not treating people with the respect that they deserve when they present to the hospital, for example. Other things are logistical and systems-wide things such as lack of insurance. We're lucky in Connecticut that most homeless people are eligible for Medicaid, but that's not true in a lot of states. And we also face people that have insurance gaps, or who are undocumented that wouldn't be eligible for insurance. Lack of transportation is a big problem. If the clinic is very far away, there's a very little chance that a person would be able to go to the clinic. And sometimes phones can be a huge barrier, where it seems like everyone in the world would have a phone these days, but it turns out that actually, only my patients that I've met and looked at this, only a third of them actually have a phone. And this is usually due to losing the phone, or having it stolen, or not being able to put minutes on a phone that they already have, and so it renders it not useful. Some clinics require a person to have an ID. Other requirements that can be burdensome are mental health treatment programs that require people to go to groups, where someone that is on the streets might not feel comfortable going to a group therapy session. Other things are requiring people to come to every single appointment without any no-shows, and that's obviously very hard for someone who's on the street, probably doesn't have a phone, definitely doesn't have a watch or some way to keep track of time, and probably can't rely on their own transportation, would rely on public transportation, which can be variable and cause them to miss appointments or be late, resulting in them being discharged from care even if they already are in care. Sometimes it's just prioritizing daily survival, like where am I going to eat tonight? Am I safe where I'm sleeping? And those things might take precedent over someone's health care or mental health care. And sometimes it's substance use disorders. This is extremely common on the streets, and sometimes that the disease of substance use disorder kind of takes over the brain and prevents people from taking priority with their mental health care or medical care. And as you can imagine, the burden of mental illness is very high among people who experience homelessness. So there's very rough estimates on this. At least a quarter, if not a half or more, of homeless people suffer from a severe form of mental illness or a substance use disorder. And this is kind of probably an underestimate, since these numbers are based on people who were asked by volunteers doing a point in time count once per year, where they ask people all around the country who are experiencing homelessness whether or not they have a mental illness or a substance use disorder. So as you can imagine, they might not self-report those kinds of statistics or figures. But suicidal ideation has been shown to be extremely prevalent. About 2/3 of people have experienced suicidal ideation in their lifetime who are homeless. Half will attempt suicide at some point. Half are also have been victims of violence. And over 1/3 of people who have a severe form of mental illness, or SMI, also called serious mental illness, have never received any care for it. And we've found that referrals are not really enough, since many places there are actual systems and clinics that would support people who are on the streets and accept their insurance and supposedly be accessible to them. When we make referrals, it's actually not enough. And even among people in one study who agreed that they did need mental health services and accepted the referral, only 1/4 of those people actually received care. And that's due to the variety of barriers that I mentioned, and in kind of preventing someone from following through to actually getting to their appointment when they're accepted for care. And some people kind of wonder which came first. Is it homelessness, or is it the mental illness that led to them becoming homeless? And it turns out one study showed that most of the time mental illness came first and then led to homelessness in a variety of ways. This type of mental illness tends to be more severe forms such as schizophrenia or bipolar illness. And it's associated with a lot of other factors that, are not mental illness alone. So commonly people who are homeless with serious mental illness tend to have a lifetime history of instability in the home and their family. They tend to be more likely to be from foster care families, to have witnessed or personally experienced childhood abuse, and are much more likely to have grown up in poverty. And so I kind of think of it as mental illness alone is not really, enough to result in someone being homeless, where many people with mental illness do not become homeless. But when you combine that with a lifetime of poverty and trauma, those kind of two things really lead to the result of homelessness in some of these cases. So, and what's been shown is that the most common disorders diagnostically tend to be alcohol and substance use disorders, and followed by psychotic and depressive disorders. But as you can see, these are really broad ranges on the percentages here. So it's not totally consistent in all of the literature that we've seen. In my experience, I've seen the most common thing is really dual diagnosis, meaning they have both an alcohol or substance use disorder and a mental health problem, non-substance use disorder together. And that's incredibly common. And then secondly, I see, the history of trauma, which may or may not result in the diagnosis of PTSD or post-traumatic stress disorder, but sometimes it does. But the trauma underlies a lot of people's stories that have resulted in them becoming homeless. And I think what's really important too is to acknowledge that racism plays a huge role, and there's a huge intersection between race, mental health, and homelessness. And if you just look at this chart diagram, you can see in the bottom the US population broken down, kind of oversimplified into white, Black, or African American, and other. And you'll see that the Black and African American population only makes up 13% of the overall US population, whereas in the homeless population, they make up 41%. And so that's a huge disproportionality that is important to recognize in all the structural components that lead to homelessness. And people of color tend to have higher rates of trauma and experience minority stress as a result of ongoing structural racism and interpersonal racism, microaggressions, and that results in mental health problems such as depression and anxiety. And in addition, there is a high prevalence of community violence in these communities often, and also a high prevalence of untreated mental health and substance use disorders, which kind of can be a whole recipe for leading to, someone to be on the edge of homelessness and kind of tip them over the edge by having all of these things working against them at the same time. And it's important to note that African Americans are also twice as likely to be uninsured because of the Medicaid coverage gap. And so one author kind of concluded that people of color who are homeless tend to have increased risk of having a mental illness, but less access. And in addition, they tend to seek emergency care, but don't have access to ongoing care. So that's just particularly interesting and important to recognize. So street psychiatry is not particularly well studied in terms of the name of street psychiatry, since this has only been named in the last 20 years since the Street Medicine Institute sort of took off. But people have been doing street medicine and street outreach for many, many years and have studied that very well under a lot of different terms, such as street outreach, homeless healthcare, healthcare for the homeless, mobile outreach, and different kinds of names. But what's important, I won't go through each individual study here, but comparing street outreach and street psychiatry, a lot of the outcomes and positive outcomes are very similar. Some of these outcomes include improving psychiatric symptoms and reducing, unwanted psychiatric symptoms, with the recognition that actually these clients are much more difficult to engage and more ill in the first place. Street outreach and street psychiatry are able to help people with substance use treatment and reduce their total days of substance use and also increase their participation in substance use programming. People who are engaged through street outreach and street psychiatry type programs have been shown to have a result of fewer days homeless. And so that's really important in terms of housing outcomes. Their quality of life has been shown to be increased by some of these programs and have a high level of satisfaction, as well as improving their global functioning. Hospital utilization is a function of kind of cost to the system, and these practices have been shown to reduce psychiatric hospitalization specifically, and also improve outpatient, which is much more cheap to the healthcare system, and shift the balance towards outpatient utilization instead of inpatient and emergency, which is much more expensive. And finally, we think of our team as also a learning environment, and it's a very valuable thing for medical training to be involved with, to kind of demonstrate how to practice a more flexible way of medicine, and in addition, kind of building empathy for a population that tends to not be given very much empathy in the medical field. So looking at what our target population is, this is very rough estimates, but in the US, there's over 500,000 people who are homeless at any given time based on these point in time counts, and many of whom are chronically homeless, meaning homeless for a year or more, or having multiple episodes of homelessness. Oftentimes that population tends to be unsheltered or living outside rather than in a homeless shelter, for example. In Connecticut, there's over 3,000 people experiencing homelessness on a given night. And in New Haven, there's over 500 people experiencing homelessness on a given night. And it's estimated that about 100 of those are unsheltered, sleeping outside. And perhaps about half of that unsheltered group is experiencing a serious mental illness or a substance use disorder, and probably more, but we don't have enough data to really conclude exactly the numbers. But that's kind of the target population that we're looking for here. And why the unsheltered homeless in particular? I think ideally we would serve all homeless people and have clinics within shelters, and even include people who are doubled up and like living at their friend's house, since they're also unstably housed. But the reason we try to really target the unsheltered homeless population, also called street homeless or rough sleepers, is that they've experienced an even greater degree of vulnerability compared to people who are homeless in shelters. There tends to be a much higher mortality rate. Apparently it's 3 times higher among unsheltered people compared with sheltered homeless people. And this is a 10 times higher mortality rate than the general population. People who are unsheltered are much more likely to have a mental illness or substance use disorder and report poor mental health, are much more likely to be victims of assault as well. There's a 1.5 higher chance of incarceration between the unsheltered and the sheltered homeless population. And finally, healthcare spending is significantly different. We see that the unsheltered spend 3.4 times more on healthcare due to the emergency room and inpatient hospital utilization compared with the sheltered homeless people. So just to give you an idea of the difference in vulnerabilities and the reasons for targeting that group. This is one of our outreach nurse practitioners doing street medicine at one of the campsites. And so I wanted to kind of pause and show this video clip about, this is about an example of what our outreach might look like. It's kind of actually a training video, so this is not a real patient, but just to show you kind of the approach, and I'll talk a little bit more about this after in a couple of minutes.
How are you?
How's it going? When we approached him, and he was really not ready to talk to us, just clearly wanted to be left alone. That may have freaked Tina out a little bit, but I think that's okay, because a lot of people out on the street are like that. They're very suspicious.
My name's Tina. This is Jeff. We're from the street outreach team. Have you heard about us before? Maybe heard around about what we do? No?
We're out on the street every day, and I haven't seen you out here before. Do you know about our drop-in center? It's over there on 4th Street, and we've got showers and clean clothes and stuff like that down there. Do you know about the drop-in center?
No. No, okay.
All right, well, here's a card that's got the drop-in center's information on it. In case you need it. Look, I'll just leave it right here, okay? And if you need anything, you can certainly come down there and ask for Jeff or Tina. We're based out of that place. And we're out here a couple days a week on outreach. Do you mind if we check in with you again?
No.
So it's all right if we come by and see you again?
Yes.
When we approach someone with a non-judgmental frame of mind, it has to do with not making any assumptions about who they are as a human being, what decisions they've made up till now, or what has caused their homelessness. I have no way of really knowing what this other person's experience is. I haven't walked in their shoes, and I can't walk in their shoes. Are you new in town?
No, I'm not.
Is there anything we can get for you? Are you hungry?
No, okay.
Need some water?
Just what?
Yeah. Would you like some water?
Yeah.
Okay.
We've got some snacks too we can leave with you.
I'm okay. I'm okay.
You just want the water? You want everyone
Just the
water
water.
too?
Water would be fine.
All right.
Would be fine.
There you go.
Okay, thank you.
It's about survival. It's really about providing basic support for people so they can stay alive on the street, giving them a sleeping bag, giving them some food and water, letting them know where the health clinic is, taking care of medical needs in the case of medical outreach teams. If you decide you need anything, you can head over there.
Okay.
Yeah.
All right.
Stop in and ask for one of us. We'll help you out.
Well, it's nice to meet you. Hope you have a good day. Take care. Okay?
See you later.
All right, so I think what I wanted to highlight here was just the approach that we take with people who are experiencing homelessness. This is fairly typical. There's a very wide variety of, being received by a person on the street. And sometimes it can be someone who's very guarded like this, who you might think that they might be experiencing a psychotic disorder and being paranoid, but it might also just be mistrust for being on the streets and having encountered healthcare providers or other outreach workers that did not follow through on their needs. And that can be, just a result of actual life experience and not even the result of a mental health problem. But their approach was, some things to highlight are that they got down on their same eye level as this man and tried not to stand over them in like a condescending way, potentially. They were very gentle in their approach. They didn't force him to answer any questions. They offered him things, and they were actually lucky that he accepted something that they offered him. And they made themselves known about who they were, so providing some context so the person's not afraid of someone approaching them who's a stranger. And they asked about whether they would be welcome to come and say hi again. So I think that's important to know as well, since we're really going into someone's home, even though it might seem like a sidewalk or a park bench or somewhere public, but that's that person's home for that moment. And we see it as we're going into their home and sort of ask permission to be there and ask permission to come back. So that's sort of to talk about the approach. I think one of my colleagues in Rhode Island actually said the most important thing is to have the patient consider meeting you again. And I think that's a really good way to capture what we do. It's about relationship building, about building trust and respect, and building, this relationship of engagement. And in order to do that, we kind of try to keep our promises, be very gentle, take advantage of small successes, such as someone accepting something from us instead of having a very fixed agenda, which can be off-putting for a lot of people. Physically getting down to that same eye level and respecting them if they say that they don't want to be outreached or talked to at that point or in the future. And this is one of my friends in Pittsburgh doing that sort of practice to a woman who is homeless in Pittsburgh, or was homeless in Pittsburgh. And to give you an idea, some of you might be familiar with New Haven. These are some of the sites that we pre-COVID used to go to. So some of the highlights are some of the encampments on the fringes of the town, as well as the New Haven Green. We also go to places that are public, places where homeless people could hang out, like soup kitchens, the downtown evening soup kitchen, the public library, and Union Station. However, since COVID, a lot of these places have really abruptly changed, such as indoor places that used to allow people to come in don't allow them anymore, such as the train station or the library. Shelters have I'll discuss in a sec, have moved to hotels. The soup kitchens have moved entirely outside, and so it's been very difficult to be homeless without anywhere to walk in or even just sit down for a break to get out of the weather, whether when it was particularly cold still in March and April, or now to get out of the sun, or to just charge your phone or relax and take a break. So now some of the other sites that are additional are a new drop-in center, as well as a tent encampment that has popped up in the west side of the city that we go to. This is the drop-in center that just invited people to come 5 days a week to get a shower, and also to connect with housing and other service providers, including our team, who we were going to this twice a week when it was at this site, and then it actually just moved to a different site when we're still going twice a week. I mentioned the decompression of the shelters, which was really important since people who are homeless have a much higher vulnerability to COVID. One, because they experience so much more medical comorbidities. They tend to be older. There's a higher prevalence of smoking, and people who are homeless tend to be more likely to be male. And then the second thing is that they're more likely to be exposed because of congregate living settings and lack of hygiene facilities and kind of inability to social distance in these settings, as well as poor access to a mask or poor access to hand sanitizer and things that even hospitals have trouble accessing. So the state did a really great thing in preventing a wider spread of COVID by moving people from shelters into hotels, so they would have at least more room and have at least one roommate, but at least that wouldn't lead to a massive outbreak if someone was exposed and contracted the disease. Other modifications that we have made because of COVID have been, it's been a much different world since COVID happened. We've reduced the size of our team to trying to do only 2 staff at a time instead of we used to have sometimes 4 or 5 people in one group. We reduce the days that we go out, but just kind of try to do more in that shorter time. We screen people for COVID symptoms and educate them about prevention, such as with this pocket guide. We wear PPE, meaning personal protective equipment, such as masks, usually at least a surgical mask and sometimes a higher N95 masks. We give masks out to the patients and try to encourage them to wear a mask while they're talking with us. We try to maintain 6-foot distance, which can be challenging when you're outside and can be even hard to hear someone 6 feet away. And we've modified a lot of the sites that we go to, such as moving to telehealth for people, the third of people that I mentioned that do have a phone, going to the drop-in center, and then going to Shelter 1, which was the COVID respite for homeless people. And so during all this is kind of a summary of what we do, both pre-COVID and currently. Is that we play a lot of different roles. I think most simply put, we do mental health treatment in the community, but we do a lot of other things as well, such as triaging someone who's in an emergency, such as a mental health crisis. We connect people with social services. We connect them with mental health treatment, whether it's in our organization or someone else that's might be more appropriate to fit their needs. We help primary care providers, especially the street medicine team, to take care of mental health problems. We help people locate the clinic patients. CMHC is our clinic that we're based out of, and sometimes people can't find the patients, so we go out to look for them. We coordinate with other providers in the community, try to address the social determinants of health, such as the phone, transportation, food stamps, entitlements, insurance type of issues. We target, opioid use disorder with Narcan, provide medication-assisted treatment such as Suboxone, do harm reduction type of activities, and only after that, after kind of the most high level of care, is that we do direct treatment, where this means that we would enroll someone as if they were a clinic patient and do all the same paperwork, all the same blood work, all the same kind of intake process, except that we're doing it on a park bench or in the community somewhere and completing that whole process, outside of the clinic walls. And the most important thing when our team was starting out was really consistent outreach. This is under a bridge where a lot of people tend to stay under bridges since it's sheltered and safe, and no one really is living there to complain about you. But really doing outreach consistently on a regular basis is extremely important, especially in building credibility with this population who, like I mentioned, tends to be mistrustful, potentially, and also really benefit and appreciate from regularity and people coming back and following through on their promises. So the way our program started, this was kind of built up through the years of 2017 to 2019. And we officially launched in about a year ago in the summer of 2019. But what we found out in the community when I was building up this program, I asked around on what is the mental health situation in New Haven, and specifically for homeless people. It turned out there was a lot of housing resources through Columbus House, and there was a street medicine program through Cornell Scott and through Yale, but they didn't have the mental health component. And so there actually had been a program many years ago, but it had lost funding. And so we wanted to bring that back. And so we added CMHC to the kind of triangle of services that were really necessary to have a complete kind of service model for people who are on the streets. And the kind of catalyst for our program starting was this event that you might have heard about now it was about 2 years ago. And in the New Haven Green, there was a huge amount of overdoses of K2, a particularly potent strain of K2. And that was very alarming to people in New Haven and people in the state of Connecticut and the Department of Mental Health. And so they wanted to combat this. And meanwhile, of course, the opioid epidemic is raging and certainly needs additional help. And people were concerned, what if that was heroin or fentanyl? And many people might have died. Luckily, there were no fatalities. And we know that drug overdose is actually the #1 cause of death among homeless people. And homeless people are 9 times more likely to die of a drug overdose than housed people. So this was particularly important, and this event kind of catalyzed funding for our program through the state of Connecticut, since there's a lot of more funding for opioid-related projects, and so ours fell under that category. So we hired a program manager on the right, whose name's James, and Eileen with the purple hair is our LCSW, or licensed clinical social worker, who does therapy and is the mental health clinician for our team, and then me in the middle. We also hired a recovery coach and have a vocational specialist now. So we take referrals, just to give you an idea about the different areas we take referrals from. It's kind of all over the place, anywhere from outpatient clinics to inpatient hospital to the outreach and engagement team that's non-clinical to the street medicine team. And then most of the time we just find our patients ourselves by doing direct street outreach. And this is kind of like just a diagram to show what kinds of encounters we kind of take care of. Sometimes it's emergency care, as you can see on this side, when we're taking care of crises and having to call 911. And then most of the time it's not an emergency, and we would kind of take the patient however, in whatever state they're in. if they're, ask them if they have insurance, ask them if they're in treatment already, ask them if they're already a CMHC patient, and go from there to decide whether we continue engaging them, help connect them, or take them on as our patient and help them come into CMHC as a primary patient. And this is just some data to show you our numbers have kind of like gone up and down since we're still a small team, but as you can see, after we started full-time last year, there's been a lot more encounters, and we've had over 748 total encounters, meaning like sometimes repeated encounters with the same person, and over 270 unique patients that we've seen. And so I just wanted to end with that. And I'm sure people have questions, and I'd love to have a discussion more about people's reactions. So thank you so much.
Thank you so much, Dr. Lowe. And we are officially open for questions now, and you can feel free to either drop those in the chat. You can click the chat button at the bottom, or if you hit participants on the right, you'll see raise hand, which someone's already done, and I'll unmute you to ask your question. And I'll go ahead and do that now. If Nika would like to speak.
Hi, thank you so much for doing this. This was very eye-opening for me on a lot of different levels, particularly because in my world headquarters in Tampa, Florida, we've had an increased amount of unsolicited homeless people unsheltered behind my office building. And we recently have acquired a contract in Connecticut near the shipyard starting in November. So the preparations for that and the meetings that we're going to be having to prepare for that are happening soon. So this awareness was very good for me. And also how to address a person like this other than just put a green sign in your window and call the police. Like even just the suggestion you said of kneeling down to eye level, even though I'm not a licensed psychiatrist, maybe that will be a more humane and understanding way to talk to a person in this situation. So thank you.
Yeah, thank you so much for that comment. And yeah, I totally agree. And I feel like sometimes what I do is just really just being a human being to other people and treating them like human beings. And oftentimes I'm not necessarily using my psychiatry training or, medical training. I'm just trying to have a conversation and build a relationship and have someone, confide in me and trust me. So I definitely agree with that.
And so what would you recommend if I found a box behind my office with feces on it the next morning as a way to respond other than calling the police?
That's a great question. We've had that actually in New Haven as an interesting problem as a byproduct of COVID, where a lot of the bathrooms were closed. All the public bathrooms that were around the city kind of closed just as a result of closing all the businesses and closing libraries and everything that would be public. And that was the result, that there was feces in the streets and in the alleyways. And the city's response, which I appreciate, was, instead of kind of cracking down on people for going to the bathroom, which is obviously a normal human function, they put up porta potties around the city and in different places where people were most likely to be homeless. And that, was a more empathic response than sort of criminalizing someone for going to the bathroom, since certainly that's not going to stop someone from having to go to the bathroom by having them arrested or something. And have, building the infrastructure to have people, just be able to take care of their basic needs is so important for everyone, and everyone wins with that, where the people are, able to be dignified and going to the bathroom, a place where they want to, and everyone else, is benefiting from the, not having to deal with a public health issue potentially. And I would just say that no one wants to be going to the bathroom outside. I think it's kind of easy to be shocked by that, but but I just hear so many people that are like, I just have nowhere to go to the bathroom, and many people use plastic bags, or just, you know, it's just a basic thing that we take for granted so much. And I appreciate that question, because I think it is so important to, like, you know, understand what kind of reactions and responses we do have, and what kinds of responses we should have in our communities. So thank you.
Thank you so much. I appreciate this lecture.
Great. And then, so I think Stephen had a question.
Where do panhandlers fit into this this picture?
Yeah, that's a great question. And we see, I think there's such a variety. You know, people sometimes say like, oh, like they're not really homeless. And that, I think, is some of the time true. But I think for the most part, the people that I've seen who are panhandling are actually homeless and are just kind of trying to get their basic needs met. I think it's easy to kind of look the other way and keep driving, which I think is kind of what most of us would do. I think it's a kind of natural human response to be, you know, in some ways, you know, repulsed or scared, or sort of just annoyed and not wanting to face that. But what I typically do, even when I'm like not working, is try to actually give them something that's not money. Like I carry around socks and other supplies, and sort of offer that as something that they might be assisted with, sort of to not ignore them, and but also not to necessarily give them money, just since, you know, I couldn't give all my patients money, and I think I would probably go broke if I started to do that. But I think what's important is responding to those people as these are just human beings. No one wants to be panhandling. It's a humiliating, horrible thing to have to do. And I've had patients that were spit on, were actually shot from a car with BB guns, and really, really horrendous things that people have done to them. And so I think that it's important to kind of, you know, give them the benefit of the doubt that they're probably homeless. You know, we don't know what they're using the money for, but they certainly can use it for their basic needs. And that, I think that's important to recognize and to keep in mind when encountering someone like that.
Thank you. And so we have a question asking, there was a mention of a student-operated program you have developed or been involved with. Can you tell us more about that program and the role of the students?
Yeah, so the student program I was referring to was in the University of Rochester, and when I was a medical student, and this program is still going on now, but I'm not as active in that because I'm now in New Haven. But the way it worked was having really kind of just the very basic things were just having medical students as one aspect, and then we found a formerly homeless person who was willing to kind of be a street liaison for us and guide us around the city to help introduce us to people on the streets for the sake of, you know, rapport, but also for the sake of having, you know, safety and someone that knows the streets better than we did. And we would go around to different encampments in Rochester and engage people and try to talk to them about their health if they were interested. And what was so profound was that there was a healthcare for the homeless clinic in the city that was always empty. I was like placed there for primary care rotation, and we hardly ever had any patients. And I knew there was a lot of homeless people in Rochester, and I saw them out on the streets when we did outreach, but they were just not coming for the barriers that I mentioned, and sort of stigma and not prioritizing their health. And so we tried to kind of be liaisons to the medical field and make them feel like we were that medicine is not a group that's necessarily going to judge them, and they were safe talking about their medical problems with us. And we would kind of direct them to either the clinic that we were affiliated with, but also had an attending family doctor who could directly help us with doing medical care for people that we encountered that needed it. But I think students play a huge role in a lot of programs around the country, and there's a national collection of students that students that have started their own programs or are interested in starting their program. So if anyone wants to reach out to me, I can connect you with that.
Awesome. And please feel free to shoot me an email if you want to be connected, and I'm happy to do so to connect you to Dr. Lowe. We have another question asking, do you have a large number of undocumented homeless in New Haven? If so, how do you handle this population? There are a lot in New York City, and sometimes there is some initial mistrust from the homeless to the outreach volunteers as a result.
Yeah, I think that's such a good point. There are a number of undocumented homeless individuals, primarily from Spanish-speaking areas. And I speak some Spanish, but not particularly fluently. But I think it is a difficult thing, because I think there's not a lot of options for them. Like, we are lucky in that my clinic can provide for uninsured people, and it's not a barrier for us. But usually these are people that don't want to be connected. They don't want to be, part of any system, because they're afraid that being part of any kind of, system where they have to put their name or their date of birth or their location, they might be found out and sent away. So our approach tends to be more kind of meeting them where they're at, trying to help them with their basic needs. And over maybe like a longer period of time, someone like this might start to trust. But I think that period of trust might be much more prolonged because of the kind of reservations that people naturally have and legitimately have for, having their own safety protected and their identity protected. But it is much more challenging because a lot of the services that are available to people, such as insurance or food stamps or unemployment, they're not really available to undocumented people. So there's less that we have to offer them, and in terms of housing and income. So.
Got it. So we have a question asking about the video that you showed, asking the questions seem a little close to each other. I think you mentioned that was a training video.
Yeah, it was a training video. So I think that it might have sounded a little bit staged. But yeah, I think there's also things that could be improved about their approach. So I think that's important to observe as well. And if maybe they didn't give the person enough time to respond, or if the questions it could have felt like they were rushing or trying to get out their information, rather than just leaving silence for the patient to respond. So that's a good observation.
And Mr. O'Connell, if you'd like to ask your question.
Dr. Lowe, thank you very much for this presentation. It's been really fascinating, and thank you for the services that you and your team provide. I had a couple of questions about the homeless problem in New Haven in particular, in terms of the coordination of the response effort. It seems like CMHC, your clinic, it's probably one of them. Is it accurate to characterize it as a patchwork quilt kind of arrangement of agencies, or is there a good central effort by either at the local or the state level to coordinate the homeless response, and how could that work better? And the second question I had relates to funding. How can a member of the public contribute in some way? What's the best way to do that? Is it primarily state and local funds that provide most of the response, or are there other, what are the best ways for people to contribute?
Yeah, thank you so much for those questions. I guess I'll start with the coordination. That's a great question. I think it has been really a patchwork up to this point, and I think we're actually working on that with our team to kind of create, instead of separate street psychiatry and CMHC, separate Columbus House, separate Cornell Scott. We're trying to build it into a broader network called the Street Outreach Services, which would encompass kind of all the agencies that do street outreach, and the housing agencies and the shelters. And I think that has been, early, just since the program manager that I mentioned that was hired last year is in charge of uniting all of these forces. And interestingly, though, COVID has actually helped in that way, because people have really been forced to really get together and pool resources and share best practices. And come together very rapidly to have a robust enough response in a fast enough way. So I've seen that be like one of the encouraging byproducts of the pandemic. The question about funding is really good. I think we're so lucky because the state of Connecticut was very responsive to one, the opioid epidemic, and two, the K2 event in New Haven, and felt that, you know, an outreach team was worthwhile to invest in. We barely bill for our services, you know, like a medical clinic would have their revenue through billing and through insurance. But obviously it's not as easy to do that if, you know, you're just having a conversation like in the video and giving someone, you know, water and socks or something. So that's not a big source of income. But we are, yeah, most of the funding comes through the state of Connecticut, which was through an opioid grant. And then we also do have a way to have people donate. We have, there's two ways, I guess, monetarily. There's the CMHC Foundation, and I can share information about these things. But the second way is that we have an Amazon wish list which was actually developed by some amazing students, and you can kind of click on things that we need and certain items that are available online, and then if you buy it, it'll be shipped to our office so we can give it out. So definitely we've had an amazing response in donations with COVID. So that's been just really important and appreciated from the community.
Thank you.
So we have another question asking, what is needed to get 100% or as close as possible of all people experiencing homelessness in the US in stable care programs?
That's a really hard question. I think, I don't know if I have the answer to that, but I think that there's so many different factors that lead to homelessness. And I think that some, you know, looking at other countries that have, you know, nearly eradicated homelessness as a public health problem, have really prioritized, you know, affordable housing and supportive housing, meaning where the housing is both affordable, meaning like not more than 30% of someone's income it's defined as, and then secondly, having support in the housing itself to have someone be successful with housing, because people have learned through the years that, you know, there's this idea of housing first, which means providing housing to people regardless of mental health problems, regardless of treatment, regardless of substance use disorders, regardless of income, and just saying like that's the stability that someone needs. And I totally believe that that is true. But then there needs to be something like housing first, and then support beyond that for extended periods of time, like up to years or more. To support that person to be successful in that housing, because we, you know, the housing retention can be pretty poor sometimes with certain programs that don't provide that support, and someone might be housed temporarily and then result back on the street. But yeah, I think addressing like affordable housing is the kind of most obvious thing, but there's other threads that kind of are precursors that lead to homelessness, such as like, you know, the racism that I mentioned, incomplete education, like lack of available jobs, difficulties with overcrowding in certain communities. Yeah, there's a lot of ways to address it, but I think there's no one right way, but certainly we're working on that and open to suggestions.
Unfortunately, it feels like there might be an increase soon given all the evictions that are now currently taking place.
Yeah, that's what we're kind of bracing for. There's already been an increase in unsheltered homelessness since the shelters, you know, appropriately decompressed and moved people indoors to hotels. But that meant that the shelters aren't really taking people. So there's more people that are kind of just stuck on a waiting list. That's like over 240 people long, I believe, and leaving them not really able to walk into any shelter and not be able to access housing. And so that's a big struggle. And then with evictions and sort of many people not being able to pay their rent for many months during this crisis, that certainly makes things a lot worse. So yeah, definitely.
So even in the, I guess the homed population is what you call it, there is such a stigma around mental illness and getting treatment for mental illness. So given that you're approaching people within their community, have you found that there's some reluctance to engage because of this?
I think there is. I think mental health problems are very personal for people, whatever population that they are. I think that the way that I try to approach it to destigmatize it is when I introduce myself, I say where I'm from, that I'm from the Connecticut Mental Health Center, so they know where I'm coming from, so that invites someone to talk about their mental health problems. Sometimes I use we can kind of bridge the topic by talking about their housing, and a lot of times housing applications require people to get a mental health assessment. So that can be another way to bridge the gap and bring it up naturally. Sometimes people bring it up to their medical provider, and then the primary care street medicine provider refers someone to me because someone brought it up to that person. But I think what underlies all of these things being successful is that the relationship has to be there first, and someone might not feel comfortable unless they trust us. And so sometimes that means months or years of going on consistent regular outreach to the same person before they're willing to open up about something so personal as a substance use problem or a mental health problem. So definitely agree with you.
We have a Nikki asking, has anyone with lived experience of homelessness played a role in designing the program in New Haven?
Yeah, so we have I'm trying to think of the name, a board of people who've experienced homelessness in that affiliated with Cornell Scott and kind of modeled off of the Boston Healthcare for the Homeless board, and we consult that. I think we probably should do a better job of consulting them when programmatic changes have happened. The other aspect is that we have a recovery coach. The recovery coach that I mentioned has been homeless herself and has lived experience of substance use disorder and mental health problems. And I think we often turn to her as the most likely person to engage with someone who has experienced the life experience that she's had and can relate and can kind of talk to people on a more person-to-person level because of her kind of identity as a peer. And then we've been actually working, because CMHC has a broad peer support network, and we've been trying to kind of involve them. And I've consulted some of them on this project, but we haven't been able to have them actually come out and do the outreach ourselves or themselves. But that's something that we're considering having more prominent as well, because I think you're totally right. It's so important to have people that actually have been there to have input on what the program is and the way it moves forward. So thank you for that, Nikki.
And we have one more question from Ms. Maruli asking, I believe you've reached out to about half of the homeless population in New Haven, and how do you search out the rest?
Yeah, so I feel like we're trying to do our job one person at a time, and we can certainly not reach all the population just by foot, and if we're doing outreach only a few times a week, but the ways that we're trying to increase that reach is through this coordination, like we're talking about the coordinating throughout the city with the street outreach services kind of umbrella, and being able to share information more smoothly between those groups will be helpful, because then people will be able to not duplicate outreach and also share when they found someone that is needs to receive mental health treatment or outreach from us. And then we're also really interested in trying to better our collaboration with Yale New Haven Hospital, since there's so many people who are utilizing the hospital, and that's the major health system in New Haven. So, and what better way to engage someone than when they're ill and experiencing a crisis and in the hospital where you can find them. And so I think that's something that other programs do really well, is have a consultation service to be able to capture from both sides, from both the street side and the hospital side, who is experiencing homelessness and who would be a good, candidate for working with in the program. And it can mean a lot to have someone visit you in the hospital when you're ill, anyone in the hospital when they're ill, but especially someone who's homeless, who doesn't have any family or friends and might be isolated, and having a visit from an outreach worker might be extremely meaningful. So we're trying to kind of broaden our reach through that way.
That sounds really great. And though I suppose, are they accepting visitors at the moment with the hospitals?
I think right now probably it's not the best time to start that kind of program, because they're not accepting visitors, I believe, and then they're also even providers are doing telehealth from one room in the hospital to the patient's room to reduce any exposure potential, but certainly in hopefully the aftermath of this.
So on a little bit of a tangent, I did want to say that I really loved your art that you put into the presentation. It seemed like you used a couple different types of mediums and styles for the portraits that you did.
Yeah, thank you. I think I did a number of things that were sketches that I did kind of in front of the person, right there, and just kind of sometimes jotted words that they were saying down and to kind of remember the conversation, and then sometimes brought that back to my studio and did something bigger with the sketch, and sometimes that meant bringing it back for like an oil painting. And although I will say I did oftentimes schlep all my oil paints out to Philadelphia and paint on the spot in the city as well. And I don't think I put this in the show, but I also did that with clay, and did one clay sculpture of someone's face by bringing the clay out to the city and doing the sculpture there.
Were they generally pretty open to being painted?
Yeah, I did it with a friend who was an anthropology major, and she would kind of engage them around certain questions that she was interested in, and I would engage them through doing the portraiture. But it's amazing that people were often very surprised, like, why would you want to paint my portrait? And no one ever really stops to talk to me. And, I would spend sometimes like an hour with them and listening to their story. And oftentimes it was very well received. And sometimes people kind of lined up as they wanted to be the next person to have their portrait done.
And then also in your bio that I introduced at the beginning, you had done some research in street psychiatry outside of the country. Can you talk a little bit about that different experience with homelessness internationally versus in the US?
Yeah, I guess the main experience that I've had was in Kolkata, and that was with a big, more like a charity organization that does street medicine, and worked with Dr. Jack Prager, who's now retired. But he designed this program going to the slums and the streets of Calcutta, which are extremely densely populated. And it's what I found is that it was more of a kind of like urgent survival based approach, as well as kind of trying to prevent very, very easily preventable diseases such as vitamin deficiencies. And a lot of the diseases that were prevalent there were different than the ones that I saw in the US, such as like tuberculosis was extremely common, and vitamin A deficiency was extremely common. And then, a lot of other things that were very striking because of the lack of health infrastructure that existed. But it was definitely a very different approach, since the just vast numbers of homeless people were so extreme that it was almost hard to really have follow-up. So that was one thing that I studied, was like how often follow-up was able to happen, and it was really difficult because it's such a huge city, and the team was very small, and we tried to kind of improve that through tracking people. So I appreciate that question.
So I think that is all the questions that we have. So do you have any closing remarks for us about the program, or what the average person can do to be helping?
Yeah, I think that I thank you for this time, and it's such an honor to speak with you guys, and thank you for your questions and interest. Yeah, I'll just say that I think what's the most unique about our program is just kind of try to break down the barriers between medical and mental health fields and homeless people. And you can certainly contribute by financial donations, but I don't expect that from people. But also just like we were talking about, kind of looking at the impact in your day-to-day. And I so much appreciate people's questions and comments about panhandling and about the public defecation and things that you can really make an impact about by educating people and influencing people's attitudes about that, which can be, most of the time it's extremely stigmatizing to talk about that. So thank you for your willingness to bring these things up and to listen to me. So it's been such a pleasure.
Yeah, thank you so much. I think we all learned a lot. And it's so important to destigmatize these things so that, because there are people just like us, any one of us could end up homeless any day. And you want to be treated like a person when you are.
Exactly.
Thank you everybody for attending. I hope you all enjoyed the lecture. We have a lot of upcoming events happening, so be sure to check out the online calendar, and we hope to see you at one of them again soon. Until then, stay safe and stay connected. We'll see you next time.